I thought I was recording everything and I had hit the wrong button. So I want, yeah. And all I got when I got home was tick, tick, tick. So I'm going now. Yay. Okay, everybody sign in. No, I got the whole back page here. Okay. All right, so quick review. What constitutes the perioperative period?
Say again, please.
What constitutes the perioperative period? Pre, intra, and post. That's correct. Absolutely. And it's a huge deal with the National Patient Safety Goals and also with the Surgical Care Improvement Project. Those are reviews from last semester. Both of those organizations look into making sure that we have patient safety through that whole period. And we spent a great deal of time last semester talking about that. All right, now we're going to hopefully watch this really cool video, on the perioperative nurse. So let's see. Okay, great. I had to
It's going around since it's
Great, thanks.
see if I can. It worked at home, but we're going to, oh, there we go. Oh, technology is not my friend. We'll see if this one works. Okay, so it says we're not connected to the internet. So what I'll do is I'm going to move on, and it's in the PowerPoints that you guys, and I'd really like you to see that video. So if you could please look at that YouTube video at home. It's a great video from a perioperative nurse's perspective of her day. She's a perioperative nurse. It's a short little video on YouTube. And she does a wonderful job of explaining just what a perioperative nurse does. And so if you could take the time when you're at home talking about it, it fulfills one of our objectives without me yammering on about what a perioperative nurse does. She's the expert. And so it's a great way of getting from that nurse's view of what a perioperative nurse does. If you're at all interested in OR nursing, as we mentioned last semester, that perioperative nurse is really the manager, the one in control, as we mentioned last semester. So if this is something you're interested in, and hopefully we will get as one of our pullouts your ability to go through the OR, and we're hoping to get that as one of your pullouts. So you'll actually get to go to the OR and spend a whole day in the OR. And one of the things that I'll ask my students when they do that pullout is watch the perioperative nurse, because they are the ones in control, and that would be a really great experience if that was something you chose to do. The fun part is obviously watching the surgery, but that's not where the nurse is.
Do their roles tend to vary depending on where they're working at?
Oh, sure.
Because I got to be pulled into one this time, and the nurse she didn't do hardly anything. She checked everybody in, and then she was on her phone.
Well, that could be, were you at the
Here
Free
in
State?
Espanola.
Oh, in Espanola. That may be that facility, but at Christus is where I've been with my students who've gone to the OR. Very different environment for that RN. They're the ones who manage that OR. They're the ones who make sure that whole space around the patient stays sterile. They're the ones who do all the charting. So while that operation is happening, they're the ones charting what comes in, what goes on that sterile field, how many sponges are used, what equipment is used. They also are the gopher. They're the ones, if the surgeon says, I need this, because they're not sterile. They don't participate in that sterile field. But they also are the ones that do all the charting. They do all the management of that care. So even, like I say, the fun part is standing as close as you can get, because you as a student are not sterile, standing and watching all the good stuff happening. The RN is back and doing all that. So take some of the time away from watching all the fun stuff happening in the wound and watch what that nurse does. Yeah.
I think most importantly, they're responsible for the right site or limb or what's the procedures being done on their mouth.
Yes, and they've gone to, they've followed what happens in the aviation industry. Has anybody read articles about that? The aviation industry does lots of checklists. Has anyone ever looked out the window on a plane and seen the pilot, the actual pilot, walk around the plane, kicking the tires and checking the wings and stuff? That's part of their checklist that they have to do to make sure that that plane is, all the things have been looked at that need to look at. Well, in the OR, this is years ago, they have created and followed the aviation industry's checklist. And they literally check everything that needs to be done, and it's greatly reduced incidences of the wrong limb, of the wrong patient, of the wrong medication, the wrong, because of allergies, and they've instituted far more checklists. And that's one of the things in the timeout, making sure that it's the right patient. They've also pre-operatively, the patient is a part of the decision making with the surgeon, the nurse, and the anesthesiologist. Everybody is around the patient, and they say to the patient, what are we doing today? And the patient says, well, you're going to be doing surgery on my right knee. And everyone says the right knee. And many times they'll hand the patient the pen, and the patient will X the right knee. And that's another, they never used to do that, but now the patient is the participant in marking what area so that it's really clear they're not going to take out the wrong kidney because they're a participant in it. So yeah. Okay. Alrighty, so I'm going to have to troubleshoot. Why? Because I have another really great video for the oncology, really good video that I want to show. So I got to figure out, I'll get IT in here and figure out why we can't connect to the internet. Okay, so now we're going to do a little group activity. You guys get to do some work. I want you to turn to 3-4 people around you, and I want you to brainstorm. You can write it on a blank piece of paper, or if you have your PowerPoint's hard copy or whatever, it's not going to be turned in. We're going to just share, so we're doing a little pair share on as many perioperative, peri meaning whole process, complications as you can think of. So we talked last semester about this, so we're just doing a little brainstorming about what are some of the complications that can happen in the perioperative procedure. So I'll give you about 5 minutes, and let's kind of dig through those cobwebs. And some of you who are reading for the first time might be able to help everybody else out. What are some complications? First, just complications. Don't think about anesthesia. Just general complications.
Yeah, we're gonna have that too.
Yep, yep.
And I added hypo and hypervolemia because you don't
Yep.
like
I still say consent. Oh yeah, for me. And make sure that or is it more? Maybe I'm going on a different route than I should be. Accessory. I don't know the spot. Make sure that if it's the same day procedure, they have a ride back home. Transportation. Okay, am I going?
Yeah, move into other problems. Think about other problems. Those are potential complications, but think about what our question was today, safety. What are all things that could fall into that? Or injury or
Sugar levels.
oh yeah, for diabetic, yeah.
Sugar levels.
What else with a diabetic put you at risk at? Yeah. That can go both ways, unique. Oh, that can go both ways, right?
And so you want us to just send the anesthesia?
No, don't look on anesthesia yet. We'll come to that later. So just general complications. So when somebody goes into surgery, what are things that can go wrong? What are yes, bleeding. Bleeding is definitely a complication. What are some other complications?
Respiratory depression.
Yes, yes, good. You're right on the right track. What are some other things? Yes. Okay, those are all things you assess.
yeah.
But what are some complications? It could be related to this and this. Or what would be a complication if they're too much or too little, right?
They could have like hypokalemia.
Yes, yes, yes. So just think globally. What are all the complications that could happen? Bleeding is right there. Respiratory depression is right there. What are some other things that could happen? Think about somebody going to surgery. There's tons of things that could go wrong. Anaphylaxis, absolutely.
Oh crap, the word's on my tongue, I can't think of it. Physical therapy?
and even general
How's this side of the room doing? Good? Yes, very good. Good. How are you? How's the guys doing over here? How are you guys doing over here?
Well,
What do you got?
drug interactions,
Yes.
infiltration, allergy, aspiration, anxiety,
Good.
hypothermia,
Good. You're on the right track. Perfect. All those are good. Okay, you guys working on this already?
I did
Okay.
that last night, I'm
Oh,
sorry.
you did? No, we're going to get there. You're ahead of the
couldn't
game.
help myself.
I'm totally appreciative that you did it last night. Okay, look at this page. I love chaos. Okay, good, good, good. All right, so finish up your thoughts. All right, let's hear from some of the groups. What were some of the complications? Just shout them out. Oh, wait, I shouldn't have done that because you took me literally. Okay, over here, give me one.
allergies.
Yeah, allergies is a big one. What did you guys have?
Medications like blood thinners.
Yes, medications, the ones, yes, that could be a problem. What did you guys have? Give me one.
Respiratory depression.
Yes. Okay, good. Back here.
Infection.
Infection, big one, right? Okay, you guys?
But we just, like a big one we thought was a lack of education from the patient, they may not tell you that they're on any of the herbal medications or anything.
Oh, yes, that can be a big one. Good job. Over here?
Malnutrition and obesity.
Malnutrition. That's both directions, right? Overweight, underweight can both be complications. Back here?
Cardiac issues.
Cardiac issues, absolutely.
They don't follow the perioperative instructions like NPO.
NPO, yes, which can lead to aspiration. Guys,
Hypothermia.
hypothermia, because what do we do in the OR that can actually lead to that? It's very cold in that room for a good reason, which is we want to keep that BMR down, but it can lead to hypothermia, which is a big complication. What about up here?
Dehiscence and evisceration.
Yes, post-surgical dehiscence and good, excellent, you guys, perfect.
What about if they forget to take out dentures?
Dentures. Now, anybody remember from last semester, what about dentures? Do we want them or not? So some anesthesiologists want them, some don't. Why would an anesthesiologist want them?
Help keep tube in place.
The shape of the mouth. They might want them, but many of them don't because of breaking. Okay, so it really depends. A lot of times, what do we do as nurses? We send them. In a cup, we'll send them with their name on them in a cup. So they to decide down there whether they want them or not. What about hearing aids?
Yes.
Yes.
Hearing aids and glasses.
Glasses and hearing aids go, for sure, because if the patient can't hear, then they don't get to answer any important questions or learning. Yeah, yes.
When my daughter had her tonsils taken out, they checked her for loose teeth
Ah,
in case they came out during the procedure.
and she could aspirate those.
Yes.
Yes, big problem, right. Okay, excellent, you guys. So, yes, sir.
Did you say some anesthesiologists don't want dentures because of breaking? Is that what you said?
Yes.
Okay.
They don't want to break those dentures because dentures are not cheap. And they don't want to have to pay for replacement of those dentures. So, but we send them anyway, because sometimes when they have to intubate, if their dentures collapse, if they have their dentures out, it collapses their mouth, it can be more challenging to intubate. So we send them in a cup with their name on them and to make sure that they are identifiable. And we let them decide. Okay, excellent. So let's see. Other complications I didn't hear were DVTs, pulmonary embolism, nerve problems. If they nick a nerve, that can be problematic. MI, we heard cardiac. Intubation problems. If they get the tube in the wrong place and the air goes into the stomach instead of the lungs, that's a big problem. A GI obstruction can be a problem, and everything else you guys hit that I wrote down. Table 16-1, page 258, lists a whole bunch of complications. They pretty much fall under our question of the day, safety or potential for injury. So we pretty much hit that. Now, the next part of the question, this is one of our objectives for today. Local anesthesia, general anesthesia, and conscious sedation. So what are the complications with each of those types of anesthesia? That's one of our other objectives that we need to hit for today. We talked about these last semester, so this semester we're focusing on the complications. So we need to look at those. So we're going to work as a large group here, and I'm going to fill in the blanks for you. So with general anesthesia, quick review. What happens in general anesthesia, gang? A little louder, okay? You're out. Do you breathe on your own? Oh, you don't. You have to be intubated under general anesthesia because general means whole body. We give you medication that puts the whole body to sleep. So they're intubated. We are breathing for them. So with us that knowledge, what do you think would be some complications here? Respiratory, yeah. A little louder. Malignant hyperthermia, absolutely. Because we're taking over control of the body, and when the body no longer has those internal controls, then we can see some serious complications. So unrecognized hypoventilation. The body no longer controls its own ventilation. Anesthetic agents, allergic reaction. The anesthesiologist come and talk to the patient to say, have you ever had this drug before? Have you had problems with this drug? Because there's a huge risk they're going to have a reaction. Intubation problems, as I mentioned before, right? They could have problems getting that tube in there. I actually worked at a hospital where the anesthesiologist got the tube in the wrong place. The patient died because they were intubating the stomach, not the lungs. Not pretty. Now, what do you think? Has anyone been intubated? How did your throat feel?
It was bad. The second time they did it hurt for about a week.
Yeah, yeah. Minor, but nonetheless a complication. It's very irritating to the throat. Very irritating to the throat. We talked about, I'm trying not to say your names because it's tape recording, but what you mentioned, malignant hyperthermia, is a huge complication. Big complication, okay? It is an muscle disorder, acute life-threatening complication. Poor thermal regulation, it increases calcium levels, increased muscle metabolism, increased potassium level, leading to acidosis, cardiac dysrhythmias, and high body temperatures. So you can see there's lots of problems if that kicks in. Yes, I sure will, and I am again taping, which will be on the on the blackboard. Inherent in muscle disorder, acute life-threatening complication, poor thermal regulation, increased calcium levels, increased muscle metabolism, increased potassium levels, leading to acidosis, which should make sense from our fluid and electrolytes from last semester, cardiac dysrhythmias, which also should make sense with those potassium, and high body temperatures, hyperthermia. Okay, so we're going to be monitoring for that during anybody who has a general anesthesia who's intubated. Another problem with general anesthesia is overdose. Patient's metabolism and drug elimination are slower than expected. Which age category are we talking about? Elderly, that's right, because the drugs stay in their system longer, they have slower metabolism, their liver doesn't function as well, their kidneys don't function as well. So those are the people we're going to be watching for. Okay, now let's look at that local anesthesia. What is the difference between local and regional, you guys? Where did I hear somebody? Yes. Topical, but it can also be, there's more than topical. What else can you do local? A little louder.
Local infiltration.
Local, and give me an example, like topical we know with like a cream or something, but local infiltration is
like for a laceration repair, you would inject lidocaine around the wound.
Correct. Everyone here? So also if you're starting an IV, sometimes we use lidocaine that we'll put around the site so they don't feel the IV start as well. So it can be like a sub-Q, and we describe those like little bee stings. So that's a local, okay? Locally around the area where we're working. Now what about regional? A little louder.
Region of your body, like
Yeah.
the arm, the leg.
Yes, exactly. So in a specific area of the body. So a regional, let's say we want to do a hand. We'll do the whole arm might get numbed to do the hand. Okay? Or if we're doing a leg, we might do a spinal. that we might do. So that's a regional, not the entire body. All right, so knowing that about a local, what would be some complications here? Infiltration, absolutely. Okay, what else? Anaphylaxis, yes. Little louder.
Like the technique of incorrect delivery, not putting enough, or not giving enough, or giving it in the wrong spot.
Absolutely. She is so right, and that can, especially with a regional. Local, not so much, because it's in the sub-Q area around there. For example, if you're starting an IV and you give some local in the area and it doesn't take, it's not quite as traumatic. But if you're trying to do a hand and you do a regional and you don't get it in the right area, that's pretty traumatic for a person to be having their carpal tunnel taken care of, and it didn't take. That's so absolutely perfect answer for the regional. Yes, sir.
Cardiac arrest.
You can have a cardiac arrest if it goes the wrong way. Oopsie. This is not good. We see that often with spinals or epidurals, mostly spinals, if it goes the wrong way. If you have a spinal, it's supposed to go this way, right? What if it goes this way? They can't breathe. Bummer. This is not good. So whenever you're working as assisting a physician with a spinal, always monitor the breathing. Expect it to go the wrong way, and you'll be happy when it doesn't. Monitor that breathing. If you're going to have them on an automatic blood pressure and pulse, right? But we don't have automatic respiratory. You'll have them on an O2 sat, but you're going to notice the breathing becomes shallower, went the wrong way. And you don't know who's going to go the wrong way, so you always monitor that breathing. So those, okay, anaphylaxis, you got incorrect delivery, systemic absorption, which I just mentioned, overdose, local complications. The nurse observes for CNS stimulation followed by cardiac depression, which are indications of a systemic toxic reaction. Assess the patient's signs and symptoms looking for restlessness, headache, blurred vision, tremors, seizures, increased pulse, respiration, BP, incoherent speech. So these are things that you would expect when it goes the wrong way. That it's, pardon me? It could be infection, absolutely. Now, are we going to see infection right away? No, but you want to monitor that site. Absolutely monitor that site. Early complications before we get to an infection might be edema and inflammation. So absolutely, we're going to look for that before it gets there. All right, conscious sedation. What is conscious sedation? What's that? You're awake. But what describe this for me.
They say you're awake, but you don't remember anything.
And what's the drug that does that short?
Versed.
Yes, it's a lovely drug. Versed, it's a lovely drug. It makes colonoscopies doable. Yeah, it's a lovely drug. It has that wonderful short-term memory blocking. Unlike general anesthetic, which wipes out and you wake up going, I've lost some time, Versed doesn't do that. It just makes you not remember. It's a lovely drug. But it's conscious sedation. So when you have a procedure under conscious sedation, you are still breathing on your own. You are still aware so that the doctor could say, I need you to turn on your right side, and you'd be like, okay, and you turn on your right side. Okay, but you don't remember it. Okay, what are some complications with this type?
You could pull out the lines.
Yeah, you're aware enough you could pull out all kinds of lines and stuff. What else? Allergic, of course, yeah, absolutely. You could be allergic to, because you get Versed and pain medication, usually a morphine derivative. Okay, what else? You can come on and bring it in. You're going to be tempted with the smell of pizza. What else?
teratogenic.
Yes, yes. So you don't want to be pregnant when you're getting that medication. Teratogenic, absolutely. Okay, so as the nurse, you need to monitor during and after the patient's response, airway, because you could get too much. Level of consciousness, you're going to be monitoring CO2 because it can, the other medication along with it, it potentiates. What do I mean by potentiate? When you, it what?
Make it stronger?
Makes it stronger without giving more, correct. So they often, depending on the age, might be on an EEG, vitals Q15. You have to monitor that patient as they come off that med to make sure they come back to baseline. Okay, so those are the things of the local general and conscious sedation that we want to focus on, complications and a little bit of that nursing role. All right, questions for me? Are we good? Yeah, go ahead. You know that you're these students' best friend right now. Okay, so now another objective is we want to look across the lifespan. And your textbook pretty much focuses on the adult, and more than just the adult, the older adult. So what I've done is I did a little more research, and I did pulled some things from your PEDS book, and that's partially for this discussion and partially to prep everybody for your PEDS rotation. I'm a really big fan of Eric Erickson. You guys all remember him? Is he still alive? I don't know if he's still alive, but he's done some amazing work with developmental stages. And I really advocate for his work.
He died in 94.
Did he? Oh, thank you for looking that up. And his work is still very much applicable to today. So I think looking at his work as it pertains to nursing, you'll still see his work in every nursing book. It's referred to in, this should be everybody here.
Thank you.
And I came across this when I was cruising the internet. And then I also came across this one from, let me see, where is this one from? And it's a little broader than just, it's an article, a chapter, a piece of a chapter out of Human Development by a couple of individuals, chapter 15 from Online Learning Center. And it's broader than just hospitalization, but it focuses on middle adulthood, which again, I don't think your text does a very good job of looking at more than the older adult. And I really think we could benefit from breaking it down into categories a little better than just the older adult. Plus, it's an objective that I think it's worth addressing. Why am I counting wrong? Oh, so I'm not losing my mind? Five, right? Five. Okay, this should be everybody. All right, so I'm not going to talk loud. Yeah. All right, so the first handout I gave you I thought was a really good, thanks, sorry you guys, I just can't yell, developmental stages, and I liked that it went on to give us the tasks, what to ask, what to look for. This one specifically adds hospital, which I really think this is what we're going for here. And then teaching approaches, because especially for us as we go into the hospital for pediatrics, I thought was really good. And what I added, and I'll go over my notes as I'll talk about that, but I really liked how this addressed that. And so I went ahead and did the whole thing. It goes into school age, adolescent, young adult, and middle age adult. And on the back is the older adult. So I thought this was an excellent handout. It's something you might want to keep all this semester and even into next semester. You might find it valuable even with your preceptorship, depending on where you end up, because it's quite applicable even today. One of the things that I will tell you that I have seen in my practice is when a person, regardless of age, and we'll talk about it with pediatrics specifically, when they're under stress, and hospitalization is a stressor, they often regress. They will regress to their most comfortable stage. So it's really quite normal for a pediatric patient, let's say they're a preschooler, they can regress to an infant and want a bottle because that's when they felt most comfortable. Adults can often regress to adolescence. You'll see behaviors you're like, what is going on with this patient? But they might have felt most comfortable, and they will not, all behaviors, but some of their behaviors they will regress to. What our job as the nurse is not to make them act their age. Our job is to recognize where they are and why they're there, because they're under a tremendous amount of stress, and approach that behavior from Erickson's what is their comfortable stage with teaching how to get to their comfort zone. So that's why this is so valuable, is when you assess someone who has regressed, meet them at that regression, because that's where they're comfortable. Our job is not to judge. Our job is to help them where they are. So that's why I thought this was such a great handout. Okay, now, I'm going to start with toddler, even though there's no box here for toddler. So in my recording, you'll get toddler before we get to school age. The reason I did that is even because when you're in pediatric rotation, you're going to see toddlers. You're going to see quite a few toddlers. You'll get the older ages, but there'll be lots of toddlers. So stressors in the hospital come under two major areas: separation anxiety and loss of control. Loss of control covers every age group. Separation anxiety is mostly toddlers and young school age. Reactions to hospitalization is influenced by developmental age, previous experience with illness, separation or hospitalization, and coping skills. So you might have a child who's been sick from birth. They will react to the hospital very, very differently than a child who's in the hospital for the first time. Okay? All right. Also, what affects them is the seriousness of the diagnosis. So if a child fell and broke their wrist and they're in because it's a little more complicated surgery versus a child who's been diagnosed with a bowel obstruction, their reaction is going to be very differently than each other. Okay, so the seriousness and the support system. One of the hardest things for my students in past pediatric rotations has been a child who is born or dealing with addictive parents. They have a very hard time when the parents seem to be totally disengaged with that child. They're more interested in their own self-needs. We're not there to judge, we're there to help. Okay? So you provide care regardless of what the family dynamics are. And we do our best with those peds patients and the families, regardless of the fact that that child is addicted, and we're working on getting them off of those drugs. Okay? Even though that mom could care less about that child, that's not our job. All right, we see some pretty horrific things on the pediatric unit. It's not our job to judge. Okay, so specifically toddlers. It's a major stress for children, separation anxiety, 30 to 60 months. And in your PEDS book, and this is as you prep for pediatric rotation, box 21-1, page 613. This is something for you to review before your rotation, okay? Separation anxiety is really big for these little guys. It's the greatest stress imposed on them. It talks about the different phases that they go through. So that's why I want you to read it before your rotation, okay? It's
What page again?
613 in PEDS.
Oh, yeah. Okay,
PEDS, okay? In PEDS, make a note of that. So this is for your PEDS rotation. All you need to know for med-surg is separation anxiety is big for toddlers. I'm not going to test to the stages, because that's for pediatrics. But I bring it up here because we're talking about across the lifespan. And so you just need to know for med-surg that separation anxiety is a big deal for toddlers.
Where is that in the med-surg?
It isn't.
Oh, it's not?
No.
Oh.
You will not find toddlers, school age, young adults, middle adults. That's why I gave you handouts. It isn't in your med-surg book. But our objective is across the lifespan. So I supplemented with handouts. Okay? Yeah. Okay. Now how many of you have toddlers? Or have had toddlers? What's the first thing a toddler does when you say, you need to pick up your toys?
No.
That's right. So that doesn't change in the hospital. You know, their job, as we know from Erickson's, is they are working on that independent streak, right? So striving for autonomy. When they meet with obstacles, they react with negativism, which is a fancy word for no. Temper tantrums, and they can react with regression. So if a toddler becomes quiet and introspective, that doesn't mean they are agreeing. They just have shut down. That's not a good sign in a toddler. Okay. All right, let's move on to school age. School age, the family doesn't play as big a role, but they did a study recently, and they asked school-age children what their biggest fear about going to the hospital, and it was the being separated from their family and friends. So it's still important. Now, school age is a big group of students, right? We're talking 1st grade to 8th grade, big group. So the younger school age are more concerned about separation than the older school age. So it's a big group that we're worried about. They also are striving for independence and productivity. Their biggest fear is disability, death, abandonment, permanent injury, loss of peer acceptance, because their peers carry on without them, and their inability to cope. Now, what do you think we as nurses can do to help these school-age kids adapt? What do you see at home with school-age kids that works? Include them. Does anybody have a school-age kid that likes to cook?
Yeah.
Yeah, so you include them in cooking. So in the hospital, you include them in their care. Help me do this. We need to get this done. Why don't you help me make the bed? Why don't you put the pillowcase on? Why don't you help me do this? Have them be productive little worker bees. That's right. So if you can give them a measure of control, even limited control, they respond well to the procedure. Help me set this up. We need to set this up and get to do your dressing change. How about you help me put this in order? Okay? You need to relate to them on their own level, so you have to be a careful assessment. What can they and can they not do? What's their intellectual level? Okay. Now, Adolescents. Adolescents. They have variations. Some of them might be a little stressed about leaving home. Some of them might go, yeah, baby, I'm out of that home. I can be on my phone 24/7. So it really depends on the adolescent, right? They are struggling for independence. Their job is to create their own life, which is why they have trouble with their parents, because they're trying to push away. They want self-assertion. They want personal identity. What do you think their biggest stressor is as an adolescent in the hospital? Not being with their peers. Absolutely. They are most afraid that their peers are going to carry on without them. So they are afraid of being away from their support system, a major situational crisis for them. Now, studies shown, though, even though we let the peers come, they can shut down from their peers because they don't look like them anymore. They don't fit in with them anymore. So sometimes it helps having the peers there, sometimes it doesn't. The best thing we can do is let them decide. If they want their peers to come at 10 o'clock at night, we let the peers come at 10 o'clock at night. Visiting hours should not dictate for adolescents. Okay. They often react with withdrawal, uncooperativeness. A lot of the staff will call them as unmanageable and difficult. We should not buy into that game. If we have a staff member that's close to their age, they should be the ones caring for them. The closest to their age should be the one caring for them. And they should talk to them on their level, use their language.
What did you say they react with love?
They can be aggressive, shut down, belligerent, combative, not like physically combative, but snotty language. So the best is get someone their own age, or the other person that works well is grandma or grandpa. That's the other person that'll work well with an adolescent. So someone close to their age or grandma and grandpa. Well, they'll work well with them. Okay, young adults, they're in the 18 to 30 year age. How many of you are in that young adult, 18, 30 year age? What's your major goal in life? Major goal for that young adult? What's your major goal? Getting a job, making money, getting your life in order, right? Yeah. Yeah, so basically the young adult is trying to get their life in order. Make money, maybe get a house, get their life in order. So if they end up in the hospital, what are their concerns? Bills, that's right. Who's going to take care of the bills? Who's going to take care of the kids? Who's going to, run the house? The biggest problems is role change and money. And if the person that's in the hospital is the major breadwinner, they're going to be stressed out the end. They're going to be totally stressed thinking about who's going to pay for this? Who's going to pay for the bills at home? Who's going to buy the groceries? Where's this money coming from? And that's a huge stressor for that age group. And then the older adult, what are all the problems? This is an easy one because it's in your med-surg book. They talk about it all the time. The older adult. Now there's middle adult, which is in the second. Let's look at that first, the middle adult, which is this second handout.
I just thought, young adults are worrying about financials, and it's just popped in my head that they think they know everything, they'll figure it out.
I'm saying nothing. I'm not going to touch that with a hot poker.
My son meant, not you.
Okay, so this one handout is the middle adult. And the middle adult, this one goes through quite a lot, and a lot of good information that goes through the distinguishing feature. Most of the time at middle adult, not always, because sometimes in middle adult we say, okay, this time's for me. I'm going to go back to school and get my nursing degree. which many of us in the middle adult, that's what we did. We said, finally got these kids out of here. Finally got, got this taken care of. I'm now going to do something for me. I'm going to go to nursing school. So but many of us in middle adult, we've reached a point where we don't have to stress as much about finances. We tend to be in a position in our life where things have settled down, if you will. Then it talks about physical changes on that page and the health factors. Do mature adults think differently? Accounts for creative achievement, work patterns, and value. So it doesn't specifically say hospital, but I think you get a picture of who this person is, and that can extrapolate if they're in the hospital. So knowing that, what do you think might be some stressors about middle adults? Grandkids, maybe. Because usually middle adults, the kids, or if they started late, it could be the kids. If they didn't start late, if they started early, it could be grandkids.
Is this the beginning of a downward spiral of my health?
Maybe. It depends on how good you were as a young adult, because those things come back to get you. Yeah.
So yeah, when you start worrying about like menopause and changes. And
Could be worrying about those things, the changes that occur. Yeah.
or your spouse's health.
Mm-hmm. Yeah, you could have some catastrophic that happens, and now you're worried about,
Or vice versa.
or vice versa. Yeah. Yeah. And you might also be a part of that sandwich generation where you have to worry about maybe your kids who are trying to get houses and jobs taken care of, and your parents who are failing, and dealing with your parents. So if you end up in the hospital, who's going to juggle all of that for them? So those kinds of things. It may be the beginning of some health issues for them, and they have to come to realize, oh my God, I'm not as young as I used to be, and I have to deal with some of these. So the middle adult is maybe coming to terms with, I can't run that marathon like I thought I could when I was in high school. I'm now, 49, and I can't just go out and run anymore. I have to, train. God forbid, I got to train. So those are the things with that. And then the older adult, we've studied the older adult. So the things that happen with our older adult, everything is decreasing. We've got decreased cardiac, peripheral, vital capacity. The kidneys are slowing. We've got increased blood pressure, risk for skin damage, infection. The sensory deficits are starting to take place. We've got osteoporosis and arthritis. We've got chronic diseases, malnutrition. We've got, as we age, we have impaired self-care deficits. We've got inadequate, potentially self-support systems. Post-surgical, it takes longer to process the drugs. It takes longer to get up and mobilize after hip surgery or knee surgery. We might have to spend time in rehab to get ourselves back together, and if it's bad enough, we may not get to go home again. So with the older adult, there's lots more because of the slowing of the entire system. We don't bounce back as fast. We're higher risk for infection, all the things that come with the aging adult. Nowadays, it's not unusual. Every day I read in the paper, somebody 113, somebody 110. And when I was a kid, it was unusual for someone to reach 100, not so much anymore. I don't know, those of you from Santa Fe, that wonderful lady who plays the accordion? Now, she's 93 and still playing the accordion at the bandstand in the summer in Santa Fe. It just blows my mind, you go, girl. So it's amazing how people not only are living longer, but living full, productive lives longer. Okay, so there's this long PowerPoint, but hopefully you got all that you need for that across the lifespan, which was one of our objectives. So let's take a look now at a case study. So Mr. Glinsky, 73-year-old male, has severe pain and limited mobility in his left hip due to osteoarthritis. If we all live long enough, we're going to have osteoarthritis somewhere. This is a wear and tear arthritis. He has been scheduled for hip replacement in 2 weeks. He's independent, lives at home with his wife. He is unable to work or pursue his hobbies because of the limited mobility and pain. He's excited about surgery outcomes, yet he's anxious. He's at the surgeon's office, and the nurse is providing pre-operative teaching for him and his wife. What information should the nurse include when teaching him and his wife? Pre-operative teaching. What should be a part of that pre-operative teaching? What discharge? Give me more.
Well, exercises and stuff that he'll need to do in recovery.
Exercises such as
Like deep breathing.
turn, cough, and deep breathe. Good. What else?
Preventing injury,
Preventing injuries such as,
falling out of bed, or
because he's having
in
what
the
kind of
shower.
surgery?
Yep.
And so, give me specifics. What would be important in the bathroom? Rails, a chair possibly. A little louder. No throw rugs. What should be on the floor of that shower? Non-skid jobs. Okay. What else should be taught? What to expect. And what should he expect?
It's gonna be painful afterwards, like his recovery is not
Yes.
easy.
It's not going to be easy recovery. It's going to be painful, but what will we do to help with that pain?
Physical therapy.
Well, that isn't going to help my pain.
Pain management.
Pain management. Excellent. We're going to provide pain management, rehab to help with that. What else?
Make sure that we need to make sure that they understand their meds and that they're organized and take the correct medications.
And how are they going to do that?
Well, you're going to educate them on it, but then you can set them up with the weekly medication.
Excellent.
through Sunday,
Excellent.
Pills in each one.
Excellent.
If they can't do it, you need to go to the spouse or the kids.
Excellent. What else?
Well, yeah, just back up a little. One of the things we talked about was to assess what they understand about their procedure before you even start.
Perfect. So everyone hear what this student here said? That I don't want to say his name because we're taping.
It talks about assessing, first of all, assess what your patient knows about the procedure they're going to receive.
Right. So we always begin with, tell me what you know. Tell me what you already know, then, because then you don't have to repeat what they already know, right? And then go from there. Perfect. But everything we've talked about needs to be a part of that. Yes.
So maybe in his case, you would talk to him about the replacement, actually having something foreign in your body, how to care for it, what the lifetime of his replacement, things like that.
Yes, we might add that piece to it if the doctor hasn't already. Yes.
Nutrition, like if they'd be on NPO.
Yes. Yes. And when we tell somebody they have to be NPO, what is helpful in getting them to comply?
Telling them what will happen if they're not.
Yes, telling them what would happen if they're not. The reason we want you NPO is we don't want you to aspirate, which means into your lungs, right? Yes.
It says that he's already had limited mobility, and there was somebody who mentioned that he's going to need the physical therapy. You have to tell him that it will get better, so he has to put in the effort to work through it, because he might just go back into that same lifestyle.
Excellent. Do you think he's going to be a motivated patient?
Yes.
Yeah, because he's independent. I think he will be motivated, but it's always good to say, you want to get back where you were, and your hard work will get you there. It's not going to be easy. Okay, excellent, excellent, excellent. I think you have all that. Perfect. All right, next slide on this one. So, arrive at the hospital, taken to his room, where he's going to come after surgery, show him the IV, pain pumps, pneumatic compression devices, those are the scuds, a wound drain that he's going to get, and the Foley catheter. What is the purpose of taking these two to his room and showing him the post-operative equipment? Reduce anxiety, right?
This is a perfect teachable moment.
Absolutely.
Later on, he'll be groggy, she'll be stressed.
Absolutely. A good teachable moment. Yes.
It fosters questions and discussions about
Fosters questions. Fosters loud. So
Discussion and
discussion.
questions, concerns.
Yes. So nothing will be a surprise, will it?
Goes under general anesthesia, wakes up, he doesn't know what all these things are.
Exactly. If he has general anesthesia, he wakes up, all of a sudden he's got scuds on, he's got a Foley in, he's got IVs, he's got oxygen. He's like, why am I tied everywhere to stuff? Yes, excellent. Excellent. Perfect. Perfect. Next slide. He's in bed waiting to be taken to the suite. The nurse administers preoperative medications, including anti-anxiety and opioids. What safety precautions should the nurse take?
Bed rails up.
Bed rest rails up.
The antidotes for that opioid.
Well, you don't necessarily pull the antidotes, but you know what they are and where to get them.
Yes.
Do not leave the patient alone.
The call light within.
Put the call light within reach. When should you have toileted him? Before you give him the meds, that's right. If he says, oops, I gotta go again, what do? Bring the urinal. You don't assist, because if you get him out of that bed and he goes on the floor, we got a problem. Urinal, after he's been given his meds. Okay, excellent, excellent. You guys are smart. Okay, he returns from hip surgery, was successful without complications. On his first postoperative day, he is to get out of bed, sit in the chair, begin leg exercises, and use his incentive spirometer and turn cough deep breathe. What are the purpose and rationales for these postoperative education orders? Are there any other postoperative orders that the nurse should expect or implement as independent nursing orders? So first, let's attack the what are the purposes and rationales for the postoperative education?
He understands the importance of it.
A little louder.
So he understands the importance of it needs to be done.
Okay, so what is the purpose of getting out of bed and sitting in the chair? Yeah, mobility to prevent DVT. What else does it prevent?
Ulcers.
Ulcers.
Ulcers, skin issues. What else does it promote? Respirations, absolutely. Good. Okay. What does leg exercises? Right. Okay. Turn, cough, deep breathe, incentive spirometer. Atelectasis, pulmonary edema, and pneumonia. All of that it's helping with. Excellent, excellent. What additional orders might be in place? Pain management. Come on, dig deep to last semester. What else? PT, but those are not nursing independent orders like it's asking for. Walking. Need an order for that? Yeah?
Level of care, like what his level of care is, like, or his diet.
Well, actually a lot of these require a doctor's order. I shouldn't have said independent care. So you do need an order for a diet, to progress his diet. You do need an order for ambulation, mobility devices, but we don't need an order for,
You want them to drink water.
yes, you want to keep them well hydrated.
Comfort, patient comfort.
Yep. We need an order for the SCDs, so he has those. TED hose, he should have an order for TED hose, but they need to be on him. Right? TED hoses, anti-embolic. Splinting, when he coughs, if it's bothering him. And I think we got all of that. Okay, so, all right. Okay, the last slide, which we have run out of time, but I will post this slide because it has a lot of information I want you to have. Perioperative meds. We talked about the meds last semester. But what you need for this semester is an example of the medication when it would be used in the plan of care. So what I want you to know for this semester is not each and every med, but when we use these meds, when would they be used? So for example, an analytic or an anti-anxiety. When would we use an anti-anxiety preoperatively? What's the purpose of an anti-anxiety given preoperatively? To calm them down. And another reason we use it? So,
Do you see amnesia?
no, it's not so much.
Does it make the anesthesia work better?
Yes. If we have a calm patient, we can use less anesthesia to get the same effect. So that's the secondary reason why we use an anti-anxiety. It's also another reason why we use a sedative or hypnotic. We calm them down, they're not crawling on the ceiling, and we can often use less anesthesia and get the same effect. So anyway, I'll post this slide because I have all the information I want you to know, and it's way too much for me to cram in 30 seconds. Okay, we didn't get to the paper, which I promised you to do the paper, so I'll try and do it next class time because I really want you guys to get going on that paper, so I'll try and do it at that time. I'm sorry, what? The topic, you get to choose the topic. But I want to show you where you have to choose an evidence-based care sheet, and you find those on the library website. So I want to show you where you go to get those.
Okay, good.
So that's probably the most important thing is for me to show you where to go get those. And you choose that topic and you match it to the same topic in your textbook. And then you do kind of that paper is based on that. So I really need to show you that. So I'll start Monday's class on the paper. Okay. All right. So thank you. Oh, I'd really like to meet with my med-surg group that we're doing lab tomorrow after the orientation. If anyone in my group could stay, I'd really like to meet with you. Yes, 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 yes. From my pediatric group Friday, we're meeting in the 9 a.m. No, 8 a.m. tomorrow med-surg, 9 a.m. Friday peds. 8 a.m. tomorrow, and I'd like to meet with my group briefly, very briefly after the orientation if possible. Thank you guys.
So we have anxiety about tomorrow's exam.
Let me